So this starts from a few years back, and I've changed a couple of the minor details to protect the confidentiality of those folks who were involved. But I was working with a trainee who was Native American, and this trainee, over the course of the 3 years that we had been working together and they had been part of our program, was frequently providing some correction to other people on the healthcare team when they would use words that had a lot of cultural significance to this person, and when used in a kind of colloquial way was offensive to this individual. In particular, a couple words that came up a lot in healthcare were powwow. So this is something that we'll sometimes say, like, ooh, let's powwow before we go into this family meeting and make sure we're all on the same page. And then totem pole is another one that people use colloquially quite a bit, particularly here in the Midwest. So I need to run it up the totem pole, or this person's on the bottom of the totem pole, this person's at the top of the totem pole, that sort of a thing. And those are terms that have a lot of kind of religious, spiritual, cultural significance. This individual would often offer other options for those words. So could you just say, why don't we meet before we go into the family meeting? Or could you use the word hierarchy instead of totem pole? And had to provide this very frequent redirection. So a little background on kind of the history there. So I was working, it was busy ward time, and there was a patient who was decompensating. And this individual, who's by now a senior trainee, our residency is a little shorter than yours, went to evaluate the patient, and we had discussed it, and they were talking with the nurse and proposed a management plan, a change to the management plan to the nurse. This was a float nurse. And the float nurse said, I'd like you to run that up the totem pole before we make this change, because this patient is really making me nervous. And the resident said, actually, I already talked to my attending about this, and they're in agreement with this management plan. And also, could you please use the word hierarchy instead of the word totem pole? So I was approached about this situation by the charge nurse, who said, hey, your resident bit the head off of my float nurse here, and they feel like this is a threat to patient safety. They were trying to make sure that this had been discussed with their superiors because they were proposing a management change. And as a nursing team, we're concerned about this resident's safety, taking care of patients now if they're not gonna, we can't trust that they actually asked you about it because they were so upset in the situation and their tone was off. The float nurse felt like their tone was communicating that they hadn't necessarily addressed it with you. This is really unacceptable, the way that they talk to this float nurse, and I want you to address it with the resident and discipline this resident. So I'm going to kind of leave you with that. There's a lot of different layers to that story that we'll try to peel back as we talk together today. And so hold that in your mind. When we're together during our time, we're going to talk about what are microaggressions, what are the key features, how can you identify them, what are some common ones that happen in healthcare, particular to healthcare everywhere, and we'll talk a little bit about research that's been done in neurosurgery more specifically. Why do bystanders need to intervene? What is everyone in this room's role in terms of creating a culture where people feel supported? And then what can you do when you're in this situation? Let's say you observe a microaggression, you're a bystander. We're going to talk a lot about role as bystanders. For people experiencing microaggressions, there are some other tools you can use that are probably beyond the scope of what we'll fully talk about today. But at UW Health, one of the core values we're trying to work on in our DEI sphere is kind of making sure that everyone feels empowered as a bystander to intervene and not having that onus be always on the people who are experiencing a microaggression. So what language can you use? As we work together today, I'm hoping that we can all approach this with the spirit of vulnerability. I came to this work after a case that I was participating in as a resident, a senior resident, so I was kind of leading some of the management of a patient, and there was a very serious medical error that was really related to bias towards this patient. And that experience got me very interested in thinking about how does the way that I think and some of these biases that I might not even realize I'm bringing to care impact the health outcomes of my patients. I'm a pediatrician, so kids are super resilient, and thankfully this young person was able to do well without ongoing consequences from this medical error. But it was serious enough that, I think there's probably a bit of luck involved in that outcome, and it could have been a life-ending error. And so I'll commit to that vulnerability too, and ask each of you, if you can, to kind of emotionally enter that space for yourself as well. Coming to this work, it's crucial to have a growth mindset. So recognizing that we're all going to say things sometimes that make us want to put our foot in our mouth. And those experiences are feedback, right? So thinking of our errors as opportunities to improve and not something that defines us as humans. As a pediatrician, I'm in the business of vaccination. So when I do this work as well, I think about that kind of required discomfort in order to have a better outcome. Entering the space, recognizing that you need to make yourself a little uncomfortable in order to have change, just like you need to have that momentary discomfort of a vaccine in order to have that positive protection later. So for some of you, these concepts might be new, and kind of just even thinking about this and starting to think about your own biases might push you into that discomfort zone. Awesome, embrace it. If this is very new and you feel like I'm moving a little too fast or you want more information, I encourage you to go to that vulnerable space. Please let me know afterwards. I'm happy to give you more resources or materials. Some of you might feel like there's too much focus on DEI and related topics, and maybe just sitting here and being present and committing to, for the next 30 minutes or so, paying attention, maybe that's going to cause some discomfort. And I encourage you to do, wherever you are on that spectrum, do what you need to do to get into that space of a little bit of discomfort during our time today. And then finally, accountability. So at the end of my talk, I'm going to ask each of you to commit to one change that you might make moving forward. It might be small, it might be big. And then during this time together, I'd like you to hold me accountable too. So if I say something that makes someone uncomfortable or you're not sure about, please call me in, let me know so that I can make sure we all feel comfortable in this space. We will be talking about racism and other forms of oppression. Sometimes these conversations are triggering for folks who have historically marginalized identities. If that's you and you wish to opt out, please feel free to do so. If that is not you, so you do not have these lived experiences, but talking about it makes you uncomfortable, that's expected part of the work. And so I ask you to remain in this space. So let's talk about those key features of microaggressions. Daryl Wing Su is kind of one of the leaders in this field and has coined the term microaggressions, and he defines these as the everyday slights, indignities, put downs, and insults that folks with historically marginalized identities experience in their day-to-day interaction. They tend to be subtle, unintentional, and indirect. And we'll talk about macroaggressions too, which were mentioned, but the microaggressions tend to be things that you could look at and say, like, did that just happen? Was that a microaggression? Was that intentional? I'm not sure. Oftentimes you could explain it with something else. So usually, not always, but usually the person who commits the microaggression has good intent. So the nurse in the story that I was sharing wants to prioritize patient safety. That's awesome. We all want to prioritize patient safety. That's good intent. And it was still harmful what happened to the trainee. Can represent our unconscious beliefs and is a behavioral expression of bias. So I've used the term bias quite a bit. Let's talk about that for a minute. There are kind of, explicit biases we hold. These are conscious. These are things that people might say that they have. There's been a decades-long longitudinal human behavior and attitude study that's gone on and shows that over time, so over the course of decades, personally reported explicit biases tend to be decreasing. So fewer people are saying, for example, that they would make hiring decisions based on race. And that's probably not a surprise to many of you in the audience to hear that, compared to the 1950s, less people in the 2020s say, like, I'm not going to hire someone because of their race. Unfortunately, when we look at actual hiring data, we don't see that trends in terms of our behavior has necessarily changed to match what our explicit biases are. And this is an aggregate. And this is not just in physicians, this is kind of among society at large. And that kind of leads into these implicit biases, which are more subtle, often subconscious, or things that we're not entirely aware of. They're automatic and can be harder to change. These are things that we learn over time, probably starting around the age of 3 is when humans start to develop some of these biases. And if any of you spend time around children, you know that that's also when kids start doing a lot of categorization. So like, is this a fruit or a vegetable? Does this animal live on the farm or in the jungle, kind of stuff? And that is a natural human characteristic to start to create categories. That's how we organize the world in our mind. And that doesn't just happen in young kids. We're all doing that all the time too. It's just a lot more nuanced as we get older. So we're able to see shades of gray that young kids are more often kind of like black and white. It is either this or that. And as adults, thankfully, we're more sophisticated in the way we think. But we continue doing this. And one of the main ways that we do this as adults is thinking about who's our in-group and who is our out-group. So again, we kind of develop over time this sense of like, who is like me and who is not like me. And that can shift and it can be situation dependent. So I have lived in numerous areas of the country, right? I'm a bit of a sports fan. And so in one context, I had a nanny who was working for a family, right? We were in each other's in-group as professional football fans because we were both Packer fans. This was in Washington, right? But when we were watching College Group, we were not in each other's in group because I'm a Badger fan and she went to WSU. So she was a Wazoo fan. And so this can shift. And then we also start to build this like in-group, out-group schemas, not just for who's like me, but who belongs in a certain space. And this doesn't always match our explicit beliefs. So I would say I'm an egalitarian person. I believe in gender equity. And when I was looking for a nanny for my infants, back when my children were smaller, it was harder for me to envision hiring a male nanny, even though I believe in gender equity. When you tell me to picture a pilot, an airline pilot, the first image that comes to mind for me is a man, even though I'm a woman and my aunt is a commercial airline pilot. That's still kind of part of my schema that I've built of what does a pilot look like. And so for all of you in the audience today, you don't need to shout this out, but kind of think for a moment, who do you envision when I ask you to think of a chef? What does a chef look like to you? What does a bus driver look like to you? What does an engineer look like to you? Some of you might have seen a train engineer. Some of you might have seen a science engineer. Do those people look different or the same? And that first snap image. What does a physician look like to you? A nurse? What does a neurosurgeon look like to you? All of these things are impacted by our experiences, what we're exposed to, what we see, not just what we see today, but what we saw growing up, what our culture is, and our group affiliation. So if we say microaggressions are that kind of behavioral expression of some of those biases, Gerald Wing-Sue categorized 3 levels of microaggressions. The first is what I would call those macroaggressions. He calls those micro assaults. But those are things that you see or you hear and you know, there's no question in your mind, is this inappropriate behavior? They're often things that result from consciously expressed biases, and they're usually pretty explicit. The micro insults and the micro invalidation, I think, are the ones that are a little bit trickier and a bit more subtle. These often come from our unconscious biases. So the micro insults are things that, in fact, might be intended as a compliment. So you're so articulate to somebody who is an immigrant or has an accent or a person of color. Someone might say that thinking like, I'm trying to compliment this person. And what that also conveys to that person is, I'm surprised that you're articulate. I was not expecting this excellence from you. And that is what I see as your excellence, not all these other things you might bring to the table. So those are some examples of the micro insult. The micro invalidation are when people kind of express belief that everyone walks through the world in the same way, and someone's experience of walking through the world and their perception of some of these comments or that kind of thing are invalid. Everyone can be successful if they work hard. So that assumes that everyone's kind of starting from the same place. And if somebody is not achieving a certain level of success, it's simply because of factors internal to them. It can also invalidate the work of folks who have maybe had different obstacles to overcome. Sometimes a word you hear for this a lot, I would say, kind of culturally right now, is that gaslighting. So it can make people question themselves too. Like, did that happen? Was that what just occurred? Kind of feelings there. Microaggressions have to be rooted in a power differential. So they're unique to folks with historically and systemically marginalized identities. My spouse does not work in healthcare, and he does a lot of international travel. And one of his bosses elsewhere is a white man, and he is notorious for wanting people to, when he's visiting them, hold their meetings inside of a sauna, which is like really weird at a lot of levels, right? Okay, so asking anyone to do that is inappropriate. It is more inappropriate, or it is a microaggression when he's asking female employees to do that, because of that kind of historical female oppression that females have experienced. When he asks another man to do that, it is still weird and inappropriate, okay? But you have to have that power differential. And we're not talking about kind of like boss subordinate power differential. It's really these kind of systemic things. So systemic historical racial differences or religious differences. Where has the power historically been held? And I think this kind of circles back to the definition of racism or other forms of oppression that we'll talk about today, where we're talking about systems of power, so not individually held power, but how has society been structured such that one group kind of holds more power than others, plus prejudice, and that is what kind of creates that racism or sexism or that kind of thing. We know that biases and thereby microaggressions tend to be more common in high risk and high stress situations that engender strong emotions, fatigue, where there's a high workload. In healthcare, situations of diagnostic uncertainty are more likely to create situations where bias is going to play a role, and when there's psychosocial complexity. And so when I think about a lot of these factors, I think about the jobs of all of you who are sitting here, almost always kind of higher stress, high workload sort of situations that you're in. And some of this comes back to what we call cognitive load theory, which is to say that, you know, we each have this kind of like mental capacity. This is an educational theory. We have this cognitive capacity, and the more we overload it, the less room we have for some of that thoughtful, explicit morning report M&M type of thinking, and the more time we're going to end up spending in that fast thinking sort of a space. When it comes to microaggressions, impact matters more than intent. So it may be that that nurse had a really good intention with what they were saying, or when someone says, oh, you're so articulate, that there's really good intention behind that. But what we want to think about is the impact, and not spending time making sure that the person who committed the microaggression knows that we realize that they're a good person. I think that's a basic assumption of most of us in healthcare, is that we're good people who want to take good care of our patients, who want to create a space where everyone feels welcome. But if the impact is negative on someone, no matter what the intent was, we need to focus on correcting that behavior. What are some common microaggressions in the healthcare setting? Well, we've talked about a few. I would like to share a video here, and this contains some individuals in healthcare describing their own experiences with microaggressions. Some folks have watched this and found it a little hard, especially if they have shared experiences. So again, if you're feeling like this is not a space that you're ready or able to be in this morning, please feel free to step away for a couple minutes.
So I introduced myself. I say, I'm Dr. Ajabu. This is our team. We're going to be taking care of you. And the patient scowls his face up and says, Doctor what? You must have a spear in your closet. And in that moment, I froze.
As a Muslim woman, I wore hijab for the first 3.5 years that I was in the medical field. And unfortunately, from negative experiences from both patients and some colleagues and other patient caregivers, I was faced with a difficult decision to make. And that was, do I continue covering my hair for religious reasons, or do I choose to take it off for a temporary period of time so that I can build better rapport with my patients and so that they can see me for me.
In residency, wear the same scrubs as everybody else. So all the residents look exactly the same. They're like a dusty blue. Everyone had the same name tags on. I think we might have been wearing the same gray shoes. We both had loops around our necks and we were walking from one end of the building to the other. And this woman came up to us and looked at him and said, "Doctor," and then paused and then looked at me and said, "Nurse?"
What do? You have all of your colleagues behind you. You're on the spot having to demonstrate your ability to maintain professionalism and to provide high quality clinical care. And what do?
So a couple things I want to point out about that video. One is there's one comment in there that contains 2 microaggressions and one that's not really a microaggression. And that was when the person said they were judged for being a woman, being in a larger body or their weight, and then for being a white person in a facility that had mostly Black patients and Black staff. That third one is not a microaggression. If we think about those historical systems of power that may make that person feel uncomfortable, they may be confronting some of their own feelings about privilege or spaces that they've been in and where they felt like the majority or the minority, but not the same as a microaggression. The other one is just going back to that cognitive load theory. Many of the folks in this little kind of video here were trainees describing their experiences. I live in the medical education world. Microaggressions happen to everybody, but if we think about the cognitive demands of being a trainee, learning how to be a doctor, period, as a medical student, like a lot of information that's coming in, pathology, physiology, all of this stuff. And then some people are having that brain space have to be taken up by things like, oof, how do I respond to this person who just asked if I carry a spear, for example? Or while I'm thinking about was that a microaggression? Is there, do I deserve to take care of this patient? And all of those dilemmas that can come up with this. Might be stuck on this page now. Thank you. So this is from that same kind of broad survey of people experiencing microaggressions. This is healthcare in general, was looking at physicians, nurses, and nurse practitioners, and kind of this was how it divided out, such that between half and 60% of folks report experiencing some form of bias. This was bias from patients specifically in this survey. What it did not look at was volume of microaggressions that are experienced, or do people with certain identities that intersect have different kind of volume or type of microaggressions that are looked at. The concept of intersectionality comes from Dr. Kimberly Crenshaw, and this is kind of just saying that, hey, the experiences of a Black man and a white woman don't combine to tell us what the experiences of a Black woman are. So people can have multiple intersecting identities that shape and change the way that the world interacts with them. And it's not a simple additive effect. This is true for all different forms of identity. And so some of these may be outwardly visible, some of them may not. But can all work together to increase, decrease, change, shape how somebody experiences the world. In neurosurgery in general, might not surprise too many people here. If you know the kind of general demographics of your specialty, that gender is one of the most commonly experienced microaggressions, and about 95% of female neurosurgeons have reported experiencing discrimination based on gender, whereas less than 10% of men have. And again, it would not be, it could still be bad, it could still be unfortunate, but it would not be a microaggression if a man experienced discrimination based on their gender due to the kind of historical differences in power and access to power. No statistical differences between men and women for these other kind of more common reasons that people experience microaggressions in neurosurgery. And then most of the research that's been done in your field has really been about gender. And that is partly because if you start to drill down beyond that, the numbers of people in other identity groups are too small to really meaningfully study right now. So there are, for example, so few Black women in neurosurgery that you can't do a study to see that. And if we compare, this is like probably a surprise to zero people, there was a white paper in 2008 out of your field kind of describing the need to increase gender diversity in neurosurgery. And racial diversity too, right? And certainly not matching the population. And there's a lot of research that says that as a whole, healthcare provides better care if we mirror the patient population that we serve. And that does not mean each individual provider needs to look exactly like their patients, but if the healthcare space looks similar to the populations we serve, we tend to have better outcomes. So still a ways to go there, and makes it hard to study other types of microaggressions specific to your field. All right, why do we need to intervene? When a microaggression happens, there are 4 kind of psychological dilemmas that have been described that happen to the person experiencing the microaggression. One is this clash of realities. So the person who committed the microaggression or who is witnessing the microaggression thinks it's innocent, completely innocuous, and the target thinks it reflects bias. This could be, for example, somebody consistently being misgendered, a transgender person consistently being misgendered. And the person who is doing that says like, oh, I mean, I'm really trying. I'm doing my best here. And the person who's experiencing it might say like, I get that, and I've had to correct my pronouns 15 times today, and that's exhausting. Invisibility. So someone doesn't notice it at all. We now have a lot of gender neutral bathrooms at UW Health. If you identify as cisgender, think back 10 years ago or 15 years ago, did you notice that there weren't gender neutral bathrooms? I didn't, right? Because it is comfortable for me to go into the women's bathroom, and I never really had to think about it. That was just like, oh, it's normal. This is normal for me. So sometimes folks don't even see what's missing from a space. A privileged person might say like, yeah, I agree, it's bias, but like, it's not that big of a deal to have to correct your pronouns. Just say it. Just say she, her, hers. No big deal, right? And again, for that person who's doing it 15 times a day, 20 times a day, that's contributing to their cognitive load. It's exhausting. It's taking them away from the other work that they want to be doing, the work of neurosurgery, the work of caring for my patients in pediatrics, or that kind of my research, that kind of stuff. The catch-22, so the person experiencing it is also then left to say like, oof, I want to intervene, but this person is my superior. What are the consequences if I correct them again? How am I going to be perceived? Am I going to be that annoying woman? Sometimes it can contribute to tropes about certain ethnic or racial groups if people are constantly correcting it. So then there's this decision that they're stuck with. Do I tolerate this and just decide to try to ignore it? Or do I correct it and risk, perhaps being vilified for that, or professional consequences that could happen? And it's often not the one microaggression that's bothersome or challenging for people, it's the accumulation.
For people who still don't think that microaggressions are a problem,
oh, you're so well spoken.
Just imagine, instead of being a stupid comment, a microaggression is a mosquito bite.
Ugh, it's a compliment.
Mosquito bites and their itch are one of nature's most annoying features. But if you're only bitten every once in a while...
No, where are you really from?
Cleveland?
Sure, it's annoying, but it's not that big a deal. The problem is that some people get bitten by mosquitoes a lot more than other people. I mean, a lot more. Whether it's on a date...
Oh, your English is so good.
Excuse me?
Going grocery shopping.
You know, everything happens for a reason.
I'm just buying apples.
Commuting to work.
So when are you gonna have a baby?
Watching TV.
We have to keep the Redskins' name. It's part of our culture and history.
Or just walking down the street with your partner.
I couldn't even tell you were gay.
Mosquitoes seem to pop up everywhere.
Do you know John? Give me shopping advice. I love shared.
Of course, beyond just being annoying, some mosquitoes carry truly threatening diseases that can mess up your life for years.
Astrophysics? Maybe you should try less challenging, Major.
Ow, my dreams.
And other mosquitoes carry strains that can even kill you.
He looked like he was up to trouble, okay? I felt threatened.
So next time you think someone's overreacting, just remember, some people experience mosquito bites all the time.
You're all so exotic. Wow.
And by mosquito bites, we mean microaggressions.
So it's often not the one comment, it's the accumulation that creates some of these harms, which can include higher levels of depressive symptoms, diminished patience, which is important for our patients, burnout, chronic stress, leaving medicine. If you look at kind of rates of women, people of color, et cetera, at higher levels as compared to who's entering the field of medicine, a lot lower. Where are these people going? That's not the only reason, of course, but it's a contributor. Feelings of isolation and a lack of belonging, which makes all of our jobs harder. It does not feel good to come to work and feel like you don't belong here. So circling back to the case that I started with, there are lots of factors that could have contributed here. And the microaggression in that situation, one is easy to see, the use of the term totem pole, run it up the totem pole. But also that this nurse says, well, now I don't trust that this person talked to their attending. It's a float nurse. They've never worked with this resident before, have no reason to think that this resident is a liar or does not talk. Are there other facets of this person's identity that make them kind of more likely not to be trusted? Being a woman, being a person of color, body shape and size, other factors. If somebody sees this person as not part of who I envision the senior doctor to be, can make them less likely to be trusted and listened to. And that also contributes to a sense of inadequacy in the individual who experiences that repeatedly over and over and over being questioned. That's kind of that gaslighting effect where you start to wonder like, wow, if this many people think that, are they right? And that's a subconscious thing too. For some folks, that doesn't happen at all. It makes you feel really angry. Like, this is not fair that when my colleague says the same thing, they never get questioned, and every time I'm getting questioned. Impacts our patients too. So I'm guessing that most of you have heard of ERAS, and don't worry, this pediatrician is not going to talk to you about something that you all know much more about than I do. But in a study of ERAS, BIPOC patients were even on the same protocol when controlling for socioeconomic status, gender, preoperative status, a number of other factors, more likely to have a long length of stay, twice as likely to be discharged to a skilled nursing facility. So different outcomes, same protocol controlling for a lot of other factors. And the authors were suggesting, you know what, probably some of this is related to bias and are finding that there are differences in use of regional anesthesia, institutional adherence to ERAS protocols, and how some of the kind of assistive devices, assessments of community support, presence of caregiver upon returning home, items that are used to determine what's the discharge or the disposition of a patient are applied differently based on race. So biases in some of these experiences don't just impact us as providers, they impact our patients too. And if you have an individual who has an identity that's shared by their patients who they're persistently seeing treated differently in the healthcare system, that creates a burden too. That's also hard to watch, that the system you are participating in is treating people who are part of your in-group differently is a really challenging kind of moral and social dilemma. And when you think about responding and someone's experiencing microaggressions over and over, they're getting all of those mosquito bites. We know that folks who are observers are more often in the proper kind of emotional state to respond. People who repeatedly experience microaggressions often end up in one of these like upper or lower states. So hypoarousal, where they're becoming numb, they're so fatigued to it. Or hyperarousal, that fight, flight, freeze gets activated when someone says something like a macroaggression. Whew, really hard to respond in that moment if you've received a macroaggression. As a bystander, we might still have some feelings when you see that, but more likely to be in that optimal arousal phase. All right, so let's think about how you can respond. UW Health, just so you know, has a policy protecting those of us who choose to respond, and I hope all of you do. And so this is not something where UW Health is going to penalize you or something. Patients are expected to treat everybody with respect, and we are all expected to treat each other with respect too. So addressing that situation in real time tends to be one of the hardest things because it can create some of that fight, flight, freeze. The recommendation is to find something that is authentic, so feels right to you. Efficient, this does not need to be a 30-minute talk about historic systems of oppression. Non-confrontational, we're not trying to escalate the situation or have it come to fisticuffs. And direct. So make it obvious though to observers that you saw this, and that can help ameliorate or reduce some of those psychological dilemmas of the person who's thinking, did this really happen? Did I see that? Was that what that person meant? And create a space where the person experiencing the microaggression knows that others recognize that this is happening too. A couple specific tools you can use. One is to paraphrase. So here, this person maybe is the RT and says, "Woo, I was surprised Erica asked me to change the vent settings without talking to you first. You sure have your hands full? I bet you can't wait for her to graduate." And the attending can say back, "I'm hearing you were surprised a senior resident asked you to make a minor change in the ventilator setting." They're just feeding back what that person says, but creates a moment for that person to go like, "Huh, yeah, I guess maybe I shouldn't, maybe I shouldn't be surprised by that." Same comment, different response, but can also interrupt or give that perpetrator a chance to think about what they just said. That's an interesting perspective. Tell me more about what has concerned you. So tone can matter a lot here. Tell me more, like gossipy, not interrupting the microaggression. That's an interesting perspective. Tell me more about that in a skeptical voice suggests like, I'm not sure I agree with what you're saying, but I'm gonna explore this with you a little bit further. Be objective. So here this patient says, "It's great to see you. That Erica over there is the best nurse my dad has ever had." And this attending says, "I'm glad you're happy with your dad's care. We do have great nurses here. But this woman is Dr. X, one of your dad's doctors." So they're taking the initiative to define that person's role, provide that objective information, while at the same time, not completely dismissing the compliment or negating the wonderful work that nurses provide. So a not so great interruption would be like, "Oh, that's Dr. X, she's not just a nurse," because there isn't a just a nurse, then you've committed a microaggression towards nurses too, right? But recognizing that this was an attempt to be a compliment. Sometimes that can be even more explicit. Here, this daughter took the comment even further. "She's so articulate. It sounds like you're trying to compliment Erica. She's a valued member of our team, an exceptional nurse." So Erica is a nurse in this scenario here. "I'd love to hear more about how your dad's day is doing." The other thing that this response does is redirect. So that helps you stay efficient. These interruptions do not have to be long. You want to get back to the issue at hand here. Sometimes it's hard to think of what to do on the spot. So you can also use a pat phrase. We train our residents to do this if they can't think of anything else to say. Sometimes it's a little weird and feels like a non sequitur, but it's still better to say something and interrupt the microaggression than to feel frozen because you can't think of anything and do nothing. So you can memorize the UW Health is a diverse and inclusive environment. Sometimes it's not going to fit. Okay, so my dad is, this is the best nurse. She's so articulate. And then you say, UW Health is a diverse and inclusive environment. That doesn't totally go there, but it's still preferred over saying nothing because Erica, who's listening, knows you saw the microaggression. Maybe you're still a little clumsy about how to respond, and that's a work in progress, but it signals that you have recognized that the situation happened. And then if you redirect back to the conversation, the patient might have a moment where they say, "Well, that was weird," but you've already moved on in the conversation and you're addressing their needs and why they're here. So that's kind of the recommended response in that sort of a situation. If you can't think of the elegant response, say something. It doesn't have to be perfect. Better is the enemy of good in this sort of a situation. So I just want to close with returning back to our story here. So this nurse has said to me, "I want you to address this with this resident. I don't think they're trustworthy." And they snapped at the nurse and their attitude is unacceptable. What do you do? This is a tricky one. in this situation, what we chose to do was talk to the resident and acknowledge, hey, this communication sounds really, like it was really challenging. I am sorry you are continuing to have to correct people on this language. And it sounds like the nurse kind of said that they maybe didn't think you were trustworthy. You know, how did that feel? That sounds rough. Do you think there are pieces of your identity that are contributing to this? And opened up a conversation, which the resident participated in. And then we went to the nursing team and said, like, hey, you know, this resident is trustworthy. This had been discussed. And I want you to know that I trust Dr. X to take care of patients and to contact me when there's something that is going on with our patients that I need to know about. They've demonstrated that in the past, they will do that. And so I want you to be reassured. I appreciate you're looking out for patient safety. I want you to be reassured that I completely trust Dr. X and know that she's a good doctor. It's not perfect. I'm sure there are things that could have gone better. But that's a very different conversation than I think, you know, when the charge nurse said, I want you to discipline. I think that's a different conversation than what they were expecting would happen. And hopefully allowed that resident to know that, like, we see what happened here. And it doesn't actually seem like the issue was your care. And you're a good doctor and we trust you to do that. After an event, these are some of the reporting mechanisms. HERO is the preferred reporting mechanism. Doesn't work for everybody. Here are some other options that you can use in addition to or instead of HERO. These are considered safety events. Some of the drop downs in HERO are a little bit clumsy for this. So just kind of do your best is the current recommendation for HERO use. I'm curious if anyone knows who this woman is. Yeah. So, whoops, here we go. So this is the first Black female neurosurgeon. One thing that cognitive psychologists know about bias is that exposure to positive images that don't necessarily match our in-group view can help reduce bias. There is a wonderful article that on my citation list is first that has a list of some of the folks in neurosurgery who are some of the pioneers kind of changing the face of neurosurgery. So if you want to see more awesome images and hear about folks that may or may not kind of match the schema that you have built of who is a neurosurgeon or picture a neurosurgeon, it's a great read. Thanks for having me. Any questions?
Thank you so much for this. Just one comment and a couple of questions. First comment is 30% of the neurosurgeons are women, as opposed to 8%. So that's a big statement. The question I have is that, you know, it's great to learn every once in a while about these things, occasional ground. But are there system processes put in place to educate and to mediate when problems like this happen, especially when they're hierarchical? One cannot speak up because they're low in the hierarchy.
Yeah.
The second issue about heroes. We've seen it over and over again that heroes are used to penalize certain people because whoever writes the first hero is the one that is given the benefit that they're and that's the problem because even though they changed the name of it to hero, it's still not a positive thing to do. They oftentimes who are given heroes one are reported to the program director. Why is that, you know, this is happening? Why is it that you're being accused of this? So you immediately get on the defensive unless you file the first hero, and then you can be on the offense.
Very weapon.
Yeah, I agree. I think that heroes can be incredibly problematic. I would say personally, I use some of these other resources more. And if we want to think about protecting the emotional safety of everyone that we work with, sometimes going through a hero might not be the first best thing. I think if there's an ally that you can find within your department or outside of your department, that's great. Peer support is another wonderful venue. These things are I think a challenge is that these things make it a little bit harder for kind of like big culture change, data collection, that kind of stuff. As an educator, that's not my, if I have a person in front of me who's experienced a microaggression, their emotional safety is my primary goal, not data collection. And so some of these may be better. I think what really needs to happen is to create a separate system for reporting these kind of events. The hero is clumsy for this. It's not anonymous. That makes it really difficult as well. And there should be a way to start to recognize patterns, right? Is somebody more commonly perpetrating microaggressions or that sort of a thing, but not in a punitive way. So we all have biases. This should be something, if we're having that growth mindset, to say like, ooh, we want to help this person become a better member of the healthcare team, not we want to punish this person or we're going to start calling them a racist or that kind of thing. That's not helpful to anybody. So I agree. I think it's imperfect. In terms of infrastructure, I would say right now it's left to a lot of departments to figure out on their own what they're going to do. UW Health kind of at large is creating some infrastructure. They have some training programs that are available. Myself and Sushant Srinivasan, who's a pediatric intensivist and the head of the UW Health Simulation Center, we're currently working with a Harvard Macy grant to create a simulation curriculum for responding to microaggressions in kind of the clinical setting in a quick way. We've piloted that in pediatrics. It's been really successful, working with surgery, internal medicine, and emergency medicine right now to try to see how can we translate this curriculum. But it does have to be kind of continuously integrated. Listening to one grand rounds is not going to shift the culture. I think it's going to take a long time and be a continued kind of explicit, concerted effort where people are saying, this is something that we're going to prioritize as a group. Yeah.
This is kind of a practical on the ground type question. I would say in at least like half of rooms where patients are on the phone and I walk in, they say, oh, my nurse is here. And then I stand there for a second and like see if they're going to end the conversation or if I have to have them stop. Do you have a best practice for, you don't want to insult the patient, be like, so I leave out the word actually, it's not actually I'm your doctor, it's just, hi, I'm Dr. Larson, I'm the neurosurgery resident. They called me because you have a neurosurgical problem. And then the patient does this awkward staring at you thing and they go, they let you be a doctor? And then you're like, yes, and I'd really like to talk to you about your subneural hematoma, like we need to keep going. Is there a best practice for how to navigate that and not offend your patient, but also make it very clear that you've kind of been misidentified and you do have an important role in what needs to happen in like the next steps of their care? Because it's just really awkward and it's every single day I've been out.
It's totally awkward, right? And I would guess that every woman in the room has had that experience at least once and probably way more than once in their career. It sounds like you're handling it really nicely. I agree with you. I like that, not using the term actually, that can make the patient feel awkward. If you're alone, you're in the position of having to interrupt that microaggression for yourself if you choose to. Which in that situation, I really do encourage you to do. And there are cases where patients, for example, have filed complaints because they've never seen a doctor during their whole stay, when they actually saw a doctor who happened to be a woman or a person of color or whatever, many times throughout their stay. I personally try to keep using the word doctor or physician regularly. Not everybody knows what a resident is. And while I think we all want to recognize our place in the hierarchy and make sure patients are aware of who their caregivers are, a lot of folks aren't really sure, like, what is the difference between a resident, an attending, a fellow? What are all these levels? And so I think in those cases, I try to kind of like reintroduce myself as doctor as often as possible. Our badges say physician. There's only so much you can do, right? You know, I've introduced myself multiple times, sometimes as doctor, and people are still like, and the nurse is here. And that's where other folks in this room can really serve as allies and say things like, hey, this is Dr. Such and Such. She is a highly competent and valued member of our team. I'm actually going to let her share the plan with you, and kind of not step in and take over, but kind of like elevate this person and then step back can be really helpful. That's not something you can do when you're the one receiving it. That's something that people around you need to do as well. But it sounds like you're handling it really nicely, and just keep using that word doctor and reminding them, like, I am the doctor. Sometimes I'll write it on the board really big. This is my name, Dr. Ruedinger, right? And you want them to feel safe as well. It doesn't feel good if you're in the hospital and you think you've never seen a doctor for a week. That's scary. So you want to make sure that they know who you are.
There's just a comment about this entire field of study. It is so focused on one side of the issue. There's so much research to be done on the other side where people come more than misunderstanding. What it's like to be a white neurosurgeon and to be categorized or more so, or to have your grant be judged by their own. Because it's a broad area. We need to understand where they're coming from, why, where this. From the beginning, the patient can come into the door unaware of this. There's nothing there outside world that cares for it. And we need to be from the get-go saying, this is Dr. Larson. The doctor in and we're not doing that because we're setting those people with their biases up there. Sometimes those biases.
I want to make a little comment also. We also do this a lot the other direction towards patients, and it's not always based on gender or race, but substance abuse, those kind of things. You have to be really careful about recognizing that happens, that that's just a drunk. That's just that person's that guy rides a motorcycle without a helmet. A moron. We're not going to have to worry about it. Yeah, right? So we just have to be careful about it. They're just actions.
Lots of research and data there in all fields of medicine, right? About how that impacts care. It's our biases, and it's also kind of some of these systems of oppression that are setting people up. Why is this person substance addicted? Like, how did this person end up in this situation? One of those strategies there is kind of like, it's called a but why exercise. You know, this person is here because they rode a motorcycle without a helmet, but why? Why did they ride a motorcycle without a helmet? You know, what images did they grow up with, or what's their context that's leading to some of these decisions? Thanks.
Thank you.
I'm happy